All right, let's jump right into the test day clinical algorithm for evaluating musculoskeletal bone pain. For step 2 CK, you really need strict, high yield decision logic. We aren't just memorizing a list of random facts here. We're building a mental diagnostic tree that you can deploy the second you read a clinical vignette. So here's our foundational decision tree. Whenever a patient shows up with aching bones or joints, your brain needs to automatically run through 5 rapid steps. 1. Is the pain focal to one joint or is it diffuse? 2. Are inflammatory markers like ESR and CRP elevated or totally normal? 3. What's going on with the calcium, phosphorus, alkaline phosphatase, and PTH axis? 4. Based on the history, should we be suspecting a fracture or maybe an infection? And finally, step 5. Which imaging modality actually answers your specific clinical question? Let's use this exact framework to lock down the absolute highest yield bone pathologies. Let's kick things off with avascular necrosis, or osteonecrosis, of the femoral head. This is your textbook example of focal, non-inflammatory joint pain. The classic presentation? It's this insidious groin pain that definitely gets worse with weight bearing. And on physical exam, they're going to have pain specifically on hip abduction and internal rotation. Notice what's missing, though. There is absolutely no erythema, no swelling, no point tenderness, and critically, zero leukocytosis. Now, to spot avian on test day, you really got to look for the systemic risk factors that disrupt that super fragile foveal artery blood supply. The heavy hitters are chronic steroid use, alcohol abuse, systemic lupus, antiphospholipid syndrome, and hemoglobinopathies like sickle cell. You might also see it pop up in patients with HIV, localized osteomyelitis, a prior renal transplant, or even decompression sickness. The absolute crucial point here is that because this is aseptic necrosis, meaning there's no infection, the white blood cell count, ESR, and CRP are going to be completely normal. This brings us to the imaging logic, which is super important. Early X-rays of avascular necrosis are notoriously normal. Seriously, do not let it fool you if the question says the initial radiograph is unremarkable. MRI is by far the most sensitive test here, and it'll show these classic serpiginous or kind of wavy, low-intensity lines on T1 images. If the disease really progresses to an advanced stage, well, only then will a plain X-ray show the classic crescent sign of subchondral collapse. All right, let's move down our next branch and see how this all builds. We're shifting from focal pain over to diffuse pain with osteomalacia. This patient is going to complain of widespread bone pain and muscle weakness. They might even have muscle cramps and a very classic waddling gait, or just general difficulty walking. When you see this, you should instantly be looking for a history of malabsorption, maybe celiac disease, a past intestinal bypass surgery, or chronic liver and kidney disease. The real diagnostic key for osteomalacia is a very specific lab pattern. The root cause is a severe vitamin D deficiency, specifically low 25-hydroxyvitamin D. Because the vitamin D is tanked, intestinal calcium and phosphorus absorption just drops. That triggers secondary hyperparathyroidism. So what do you see? A high PTH, which pulls calcium from the bones, leaving the patient with a low or maybe low normal serum calcium, low urinary calcium, low phosphorus, and a really elevated alkaline phosphatase since there's high bone turnover. When we look at imaging, osteomalacia usually shows up with reduced bone density and cortical thinning. But the absolute radiographic hallmark you have to know for the boards is the bilateral symmetric pseudofracture, which is also known as a looser zone. They literally look like linear lucencies running right perpendicular to the cortical margin. Let's pause for a quick active recall here to test those diagnostic reflexes. Say you have an asymptomatic elderly patient who presents with an isolated elevated alkaline phosphate, but their serum calcium and phosphorus are totally normal. What's the diagnosis? The answer is Paget disease of bone, literally until proven otherwise. This is the single most common cause of an asymptomatic elevation of alkaline phosphatase in an older patient. The reason their calcium and phosphorus are perfectly normal is because, unlike osteomalacia, the underlying issue here isn't some mineral deficiency. It's actually localized, chaotic osteoclast dysfunction followed by totally disorganized bone formation. Even though it's often asymptomatic, when Paget's disease actually does cause symptoms, it creates some intense bone pain and deformity. If it hits the skull, the patient might get headaches and even hearing loss. If it hits the spine, you can expect spinal stenosis and radiculopathy. Long bones, they can bow out, fracture, and cause arthritis in the adjacent joints. And very rarely, this chaotic bone turnover can actually transform into a giant cell tumor or an osteosarcoma. To diagnose it, X-rays are going to show mixed lytic and sclerotic lesions, but a radionuclide bone scan will reveal the classic focal hotspots of increased uptake. For symptomatic disease, the treatment of choice is definitely bisphosphonates. All right, shifting gears over to osteoporosis, you need to screen all women over 65 with a one-time DEXA scan, as well as younger women who have an equivalent fracture risk. Beyond just age and menopause, be on the lookout for risks like low body weight, white or Asian ethnicity, smoking, alcohol use, malabsorption, rheumatoid arthritis, or myeloma. Because this disease is often totally silent until a hip, vertebral, or distal radius fracture actually happens, you must do a secondary workup. Initially, evaluate them with a chemistry panel, CBC, 25-hydroxyvitamin D, and a TSH if they're symptomatic. And please remember this golden rule. The absolute highest risk factor for a future fragility fracture is a prior fragility fracture. Time for another quick active recall to test our imaging decision logic. Imagine a patient with known osteoporosis falls. You highly suspect an acute occult fracture, even though their initial plain X-ray was totally normal. What is your next best test? The answer is do not use a DEXA scan. DEXA is strictly for screening baseline bone mineral density, period. If you suspect an acute occult fracture because their osteopenia is making it hard to see on a plain X-ray, you have to proceed to advanced imaging like an MRI or a CT scan. A DEXA just isn't going to answer that acute diagnostic question. Now, for all your osteoporosis patients, you want to mandate weight-bearing exercise, fall prevention, and quitting tobacco and excess alcohol. If it's secondary, like glucocorticoid-induced osteoporosis, proactive management is completely mandatory. You have to minimize the steroid dose and duration, ensure they have baseline calcium and vitamin D supplementation, order periodic DEXA scans, and crucially, initiate oral bisphosphonates early for those high-risk patients to prevent fractures from happening in the first place. Okay, let's completely shift gears here from metabolic and structural bone disease over to the infectious branches of our algorithm, the targeted osteomyelitis diagnostic pathways. With osteomyelitis, the patient's history is everything. It strictly dictates the suspected organism, the mechanism of spread, and exactly what your subsequent workup should be. Take vertebral osteomyelitis, for example. This usually shows up as subacute back pain, really focal midline spine tenderness, and maybe a fever. It's almost always caused by hematogenic seeding, typically from Staph aureus, and it's often linked to IV drug use, catheters, or some recent infection. Here is your step-by-step diagnostic logic. Step 1, draw blood cultures and inflammatory markers. Step 2, get a plain X-ray. Step 3, if the X-ray comes back normal but you're still highly suspicious, get an MRI. And Step 4, confirm the exact bug with a CT-guided bone biopsy and culture so you can direct your IV antibiotics and definitively drain any associated abscesses. For other types of osteomyelitis, you're always looking for the clinical trigger. Was there a puncture wound straight through a rubber-soled shoe? Suspect Pseudomonas right away. A diabetic foot infection? That's contiguous spread from a chronic ulcer, and it's practically always polymicrobial. Children typically get hematogenic osteomyelitis in the metaphysis of long bones, most commonly from Staph aureus. But if that child happens to have sickle cell disease, you absolutely must add coverage for Salmonella. Let's do one last active recall to lock in this diabetic foot infection logic. You have a diabetic patient with a deep, long-standing foot ulcer. On exam, you perform a positive probe-to-bone test, meaning your sterile instrument literally touches the bone. What is the definitive next step for guiding management? The definitive step here is a deep tissue bone biopsy. Look, while imaging like an MRI is incredibly helpful to see the extent of the damage, a deep tissue biopsy is strictly required to identify the specific organisms. Remember, diabetic foot osteomyelitis is polymicrobial. You can't just guess the antibiotics. You really need that tissue culture to direct your targeted therapy. Let's execute a high-speed rapid synthesis to really secure this whole diagnostic tree in your mind. Avascular necrosis, focal pain, completely normal labs, and MRI is the most sensitive. Osteomalacia, diffuse pain, low vitamin D driving high PTH and ALK-Phos. Look out for those looser zones. Paget's disease, an asymptomatic elderly patient with an isolated high alkaline phosphatase and hot spots on a bone scan. And finally, osteomyelitis. The history gives you the bug, and the workup goes from ESR and CRP to plain film over to MRI, definitively ending in a bone biopsy. And that completes our clinical algorithm. Diagnostic logic secured. You now have the exact branching pathways to evaluate bone pain, isolate the underlying pathology, and confidently pick the correct next best step. You are completely ready to tackle these on Step 2 CK.